Swastiastu. Greetings to evaluator and facilitator. We are from B3. Now we would like to explain about student project about Infantile Hyperthrophic Pyloric Stenosis, IHPS. Here are our members that participated in the making of this student project. Let's start from Chapter 1, Introduction.
Okay, my name is Ananda Eka Raharja with last 3 digit of student ID number is 136, and I will start with Chapter 1, Introduction. Okay, so we will start from the background information. Infantile Hypertrophic Pyloric Stenosis, also known as pyloric stenosis, is a rare disorder in which the pylorus muscle of abdominal thicken abnormally, leading to obstruction of the gastric acid. Pyloric stenosis is the most frequent gastrointestinal disease in the first few weeks of life. The cause of this disease is still unknown, and the patient showed a clinical presentation including projectile non-bilious vomiting, a palpable lump in the stomach, and visible peristaltic, especially after feeding. And then the progressive symptoms can lead to several complications. Thus, a rapid diagnosis is needed to prevent complication, reduce morbidity rates, and allow surgical treatment that leads to good prognosis. Based on the description above, due to the increasement number of pyloric stenosis cases in the last decade, and as an effort to fulfill the assignment, our group discussion interested in making a student project with the topic of pyloric stenosis. And then the problem formulation, according to the problem identification that has been presented through the background, the problems convert can be formulated as follows 8 questions. Number 1, what are the etiology and the risk factors of pyloric stenosis? Number 2, how is the epidemiology of pyloric stenosis? Number 3, what is the pathophysiology of pyloric stenosis? Number 4, what are the signs and symptoms of pyloric stenosis? Number 5, how to diagnose and differential diagnosis of pyloric stenosis. Number 6, how to treat and manage pyloric stenosis. Number 7, how is the post-operative and rehabilitation care of pyloric stenosis? And last one, what is the prognosis and complication of pyloric stenosis? Okay, maybe that's all about the problem formulation. The next step will be continued by my friend. Thank you.
Hello, my name is Anggi Devy with last 3 digit of student ID number R088. I will continue the presentation about the purpose and benefits of this student project. So the purpose are to know about the etiology and risk factors of pyloric stenosis, know about the epidemiology, pathophysiology, signs and symptoms of pyloric stenosis, also knowing and able to diagnose and differential diagnosis of pyloric stenosis, knowing and able to treat and manage pyloric stenosis, knowing about the post-operative and rehabilitation care of pyloric stenosis, and knowing about the prognosis and complication of pyloric stenosis. So this is the benefits. The benefits of writing this paper for medical students and for the community is to enhance the understanding and knowledge about pyloric stenosis. This content intends to amplify the understanding of the etiology, risk factors, epidemiology, pathophysiology, signs and symptoms, diagnosis, differential diagnosis, treatment, management, post-operative and rehabilitation care, prognosis, and also complication of pyloric stenosis. In addition, the student project is also expected to be a reference for other research related to pyloric stenosis. Okay, that's all from me. Thank you.
Greetings, my name is Trifena Lisanias with the last 3-digit number 119. Today I will explain to you about etiology and risk factors of pyloric stenosis. The exact etiology of the pyloric stenosis is unknown, but genetic, environmental, and some other factors might be the risk factors for pyloric stenosis. Several studies have shown that pyloric stenosis is seen more often in boys, especially firstborn children and in children with family history of pyloric stenosis. Other risk factors, including younger maternal age and bottle feeding, smoking during pregnancy, early antibiotic use, and certain antibiotics took in late pregnancy. That's from me. The next presentation will be continued by my friend. Thank you.
My name is Bagus Prema Satia Saputra, and I will continue the presentation. In epidemiology, pyloric stenosis occurs in about 2 to 5 in 1,000 live births per year. Around 12% were from premature infant. The male to female ratio is 4:1, so it's usually in male. And pyloric stenosis is common in white or Caucasian population more than others. It is less commonly seen in Asian and Black population. So the incident rate is around 2.4 per 1,000 in white population, 1.8 in Hispanic, 0.7 in Black, and 0.6 in Asian population.
Hello, my name is Dewa. I Fony Prema Shanti, and the last three digits of my student ID number is 004. In this occasion, I will explain about the pathophysiology of pyloric stenosis. Patients with pyloric stenosis develop hypertrophy and hyperplasia of the pyloric muscle layer, leading to functional obstruction of the gastric tract. The hypertrophy and hyperplasia of the smooth muscle of the antrum and pylorus then causes narrowing of the lumen of gastric antrum. The narrowness of this area then causes it become easily obstructed. The antrum is elongated and thickened to twice its normal size. Due to obstruction of outflow and vigorous peristaltic, the abdominal muscle become hypertrophied and dilated. Gastritis can occur after prolonged stasis. Hematemesis can sometimes be experienced in patients with pyloric stenosis. Patients may become dehydrated from repeat vomiting and develop hypochloremic alkalosis. Okay, that's all about my presentation, and thank you.
Hello, my name is Sofia Paramita with my last three digit ID number 156, and I will be mentioning the signs and symptoms of pyloric stenosis. There are vomiting, abdominal pain, belching, constant hunger, dehydration, weight loss, and wave-like motion of the abdomen. Maybe that is all from me. The next slide will be delivered by my friend. Thank you.
Okay, hello Professor and hello everyone. My name is Evangelina Vincent Utami Laseda with the last three digit student ID number 170. On this occasion, I will going to continue explain about the diagnosis of pyloric stenosis. Well, when the doctor do the physical examination, an olive-like appearance was found in the right upper quadrant of the lateral rectus abdominis muscles. And the golden standard in the diagnosis of pyloric stenosis is abdominal USG, where when we do this examination, the criteria diagnosis should include a single muscular wall thickness of pylorus or pyloric greater than or equal to 3 mm and the pyloric length of greater than or equal to 50 mm. And when we do this examination, we also can see or find a target sign or a rounded mass. And well, the other examination also can be done if the abdominal USG cannot establish the diagnosis. The first one is the barium enema, where the barium enema more conclude the picture of hyperthyroid muscles such as caterpillar sign, big sign, string sign, and double track sign. While abdominal X-ray can also be used, but the level of specification and the sensitivity in diagnosing is lower. Well, that's all for the diagnosis. The next point will be explained further by my friend, and thank you.
Hello everyone, my name is Yudhistira with this number 2002511-215. Next up is the differential diagnosis. So in diagnosing pyloric stenosis, it is necessary to pay attention to several differential diagnoses such as midgut volvulus, pediatric gastroenteritis, and then there's a pylospasm, there's a GARD, as well as sepsis. There's also acute renal failure, urinary tract infection, hernia, and also, last but not least, testicular torsion. Next.
Hello, my name is Putu Yudhistira, Wardhana with three last digit student ID number 098. I will continue the presentation about the treatment and management. In here, the first important thing to do is rehydration and electrolyte for the patient. In normal or mild dehydration, we can rehydrate the patient with 5% of dextrose, 0.25% of sodium chloride and 2 milliequivalent of potassium chloride per 100 milliliters. Meanwhile, in moderate or severe dehydration, we recommend higher intravenous fluid of sodium chloride concentration. And then we should not forget to correct and monitor the level of bicarbonate. Then we can continue to consider to apply a nasogastric tube to the patient. After good hydration status has developed from the patient is good to go for the pyloromyotomy that can be done open or laparoscopically. Thank you.
Hello, my name is Angelique and the last 3 digits of my student ID number is 068. Now I would like to explain about the post-operative and rehabilitation care. The sole post-operative treatment is to keep patients on IV fluids until they are able to eat. Feeding might begin 4 to 8 hours after the anesthetic has worn off. The feeding protocol varies depending on the surgeon's discretion and the risk of developing post-operative emesis. After surgery, up to 80% of individuals experience some type of moderate vomiting. The doctor would recommend additional radiologic investigations, such as upper GI series, if vomiting persisted 5 days after the surgery. The patients should be monitored in the hospital following surgery for surgical complications, such as incomplete pyloromyotomy, mucosal perforation, and hemorrhage. And then when the patients are properly hydrated and tolerate feedings well, they may be discharged home. That's all from me. Thank you.
Greetings, my name is Felix, and now I'm going to explain about the complication and prognosis. Okay, so complications are rare, especially during and after surgery. Complication of inadequate filomotory require preparation of the mucosa and repeated procedure as the presence of an excessive filomotomy is at the end of the spectrum of complete changes. In order to determine the prognosis, the characteristics of each individual must be considered, with the overall prognosis depending on the severity and extent of all identified lesions. Okay, that's all from me. Thank you.
Hello, my name is Ketut Adelia Febrianti Puspa Dewi with the last 3 digits of my student ID number is 041. So I will continue presentation with the last chapter, which is the conclusion. So infantile hypertrophic pyloric stenosis, or IHPS, also known as pyloric stenosis, is a rare disorder in which the pyloric muscle of the abdominal thicken abnormally as a result of concentric muscle hypertrophy, which is leading to obstruction of the gastric exit. Therefore, became the most frequent gastrointestinal disease in the first few weeks of life. Its etiology is unclear, but many risk factors, including genetic, environmental, certain drug consumption, especially antibiotics, and pregnancy-related factors such as smoking and alcohol consumption during pregnancy may cause IHPS. Therefore, several symptoms that can be assigned for pyloric stenosis, such as vomiting, abdominal pain, belching, constant hunger, dehydration, weight loss, and wave-like motion of the abdomen. Therefore, a rapid diagnosis is needed to prevent complications that might happen, including incomplete pyloromyotomy, mucosal perforation, and hemorrhage, and also to reduce morbidity rates and allow surgical treatments such as pyloromyotomy that leads to good prognosis. The implementation of post-operative treatment and rehabilitation is also important for IHPS patient recovery. Okay, that's all for our presentation. Thank you for your attention.